We appreciate everyone being here with us this morning on President's Day, and you may or may not be working, or you may or may not be treating kiddos in whatever setting you're in, but we're so glad everyone is here, and we'd love to welcome you on behalf of the Asthma 411 Initiative. I am Courtney Bernard with the Center for Community Health at Cook Children's, and we are one of the partners on the Asthma 411 Consortium, along with Safer Care Texas, UNT Health Science Center, JPS Health Network, and Acclaimed Physician Group, and several school districts within Tarrant County. And so one of our goals as part of this consortium is to provide timely and relevant continuing education for school health staff who participate in Asthma 411. And we've also opened this in-service up to other school districts around North Texas and beyond. So I know several of you are joining from Region 10 and others. So glad to have you on here. Today, we're going to have two presentations by Dr. John Robertson and Abigail Hoekstra on how school health staff can best respond to episodes of asthma exacerbation. And then we'll close with a few program updates about the Asthma 411 initiative, hearing from Dr. Leslie Alsop, our program manager. So before we dive all the way in, I know several of you have been doing this already, but we do want to make sure everyone had a chance to sign in or register as you logged into the Zoom call. And we recognize we've had a couple technical difficulties with some links. So to make sure you get your CE credit, and we want to know who you are and you get all of our follow-up communications, if you would please in the chat type your name, your credentials, and your email address. And then we'll be able to capture that after the webinar today, and you will receive our follow-up communications. Some of you may also have had the opportunity to fill that in on our registration form, but not everybody did. So your name, credentials, and email address, please. As you all know, this session is being recorded so that others can view it after, not outside of just today's time here, and we'll make that available publicly on our websites, and we'll share that with everybody, so you're welcome to pass that along. And then today we are offering a 1 hour of nursing continuing education credits, so you'll see some disclaimer slides coming through here. So after the session, you will receive an email to complete an evaluation. Doing this evaluation is required to receive that 1 hour of nursing CE. But even if you don't need the nursing CE, we invite everybody to complete the survey to provide their feedback. It also gives you an opportunity to tell us what else you would love to learn or see from a future in-service. And then the recording will be posted online in a few weeks for viewing, and CE credits will be available through the end of 2024. So we will send that out by email. It will be searchable on our websites and all of that. Okay, so I believe that's our housekeeping here. And now I'd like to introduce our two speakers, and I will hand it over to them, Dr. John Robertson and Abigail Hoekstra. Dr. Robertson is a Fort Worth native. He attended Texas A&M University and then UT Southwestern Medical School. He did his general pediatric residency at Children's Medical Center in Dallas, followed by a pediatric pulmonary fellowship at Texas Children's Hospital. He was in private practice in Houston and Nashville for over a decade before joining Cook Children's in 2020 to start our pulmonology clinic in Prosper, Texas. In addition to his general pediatric pulmonology work, Dr. Robertson has a strong interest in exercise-induced breathing problems, and he performed the first continuous laryngoscopy during exercise on a pediatric patient in Texas in February 2 years ago. So when he's not working, Dr. Robertson enjoys spending time with his wife and young daughter, grilling, being involved in church activities, and making a mess as an amateur artist. Thank you, Dr. Robertson. Abigail Hoekstra, our second presenter, she is a certified child life specialist at Cook Children's in Fort Worth. She graduated with her undergraduate degree also from Texas A&M University, where she studied child professional services and ballet. So upon completion of her undergrad, Abigail taught second grade at Fort Worth ISD for 3 years. So she's got that school perspective too. Abigail completed her Master of Science in Child Life at Texas Women's University and went on to complete her professional training at Dell Children's Hospital in Austin and Children's Memorial Hermann in Houston. Abigail currently serves patients and families in the pulmonary clinic, surgery clinic, and palliative care clinics at Cook Children's. She's passionate about family-centered care, including involving siblings in care, as well as being a supportive presence and validating patients and their families' experiences. And as I mentioned before, we have set aside time for Q&A at the end after Dr. Robertson's and Abigail's presentations, so that everyone will have a chance to ask their questions. Please feel free to add your questions in the chat box or the Q&A box along the way. And our team will be able to read your questions out loud for both Dr. Robertson and Abigail to address at the end. And I will say one more time, because I've seen a couple more people join. If you did not have the chance to already, please include your name, credentials, and email address in the chat box so we make sure we capture you and we can follow up and get you your CE and any follow-up communications. Okay, and with that, I am going to turn it over to Dr. Robertson.
Thank you for having me for this talk. I really love the opportunity to talk to school nurses because y'all are the front lines for a lot of these kids, their asthma symptoms, and sometimes they're totally fine at home and only the only having their trouble after recess or during PE or something like that. And so it's you guys have a very unique perspective that is extremely important, and so I appreciate the opportunity to get to chat with y'all. I'm going to run through the disclosure slides since we've already covered those. Okay, so there's two essential scenarios from an asthma perspective y'all are going to be dealing with at school primarily. So symptoms and before exercise. So what are the asthma symptoms? So the coughing, wheezing, shortness of breath, breathing fast, chest tightness, sometimes chest pain, and then just decreased activity. I put a bunch of stars around the word coughing because I find this is a very unappreciated symptom in the world of asthma care. And so you will find on a lot of asthma plans and the prescription medicines that are like albuterol that are used PRN, docs will usually put, coughing, wheezing, or shortness of breath. Coughing is actually an earlier symptom in an asthma flare-up than wheezing. In the sequence of events where you take someone who's got a normal, healthy set of lungs, and then they start having an asthma attack, and then you end that sequence with them in the emergency room having a lot of trouble, the first symptom they usually develop is coughing. As their asthma flare-up gets worse and their lung function drops, the wheezing starts. And so it is totally fine and actually better than fine. It's what I would recommend to treat these patients with known asthma. Treat their coughing as much as you would treat or in the same way that you would treat their wheezing. Another thing worth mentioning is most of these patients, their oxygen level is fine. The reason for that is the oxygen drops generally very late in an asthma attack. In that same scenario, the patient will probably be in the emergency room on continuous albuterol treatments even before their oxygen ever became, the below 93. It's a very late indicator of severity in an asthma flare-up. And so I teach my staff, don't be lulled by a normal oxygen. If the kid's coughing every 3 minutes, that's an asthma flare-up, and we got to treat it. A question I often get from parents is, well, is every cough my patient has going to be asthma? And the answer is no. The problem is I cannot listen to the cough and decide, oh, this is asthma, whereas that cough yesterday, that was allergies. I can't tell. And so since we can't be perfect based on our, our ear's ability to differentiate causes, based on the sound of cough, we have to decide, do we want to err on the side of safety or not safety? And what I mean by that is I'd rather treat someone with asthma, with known asthma, with albuterol for a cough that didn't actually need the albuterol than I would rather do that than not treat them if they were having a coughing, but it was really asthma, because in that scenario, the kid's just going to get worse. And so I treat early and often, even if cough is their only symptom. And I teach my patients, especially the older ones, trust your bodies. If you're feeling chest tightness, even if you're not wheezing, take a treatment. And so I also want to encourage that, sometimes, especially with an in tune to their body teenager, which not everyone is certainly in tune, chest tightness, or they just may feel that before other perceptible symptoms occur. So what's happening? The normal is in the green box. These are airways. You've got a maroon ribbon of smooth muscle that wraps around all of our big airways. And in asthma, when you go over to the left image, the red outline box, you see what an airway looks like in an asthma flare-up. The ribbons get tight and are sort of squeezing, decreasing the diameter of the airway. And you also have the mucus filling the airways and inflammation causing the wall of each airway to get thick. So sort of several, all these things combine diabolically to the tubes, the size of the opening of these tubes that you're breathing through and moving air through is compromised by a number of measures. And so we treat to try to get back to normal. Just as a slight mild refresher here, your quick reliever medicines, that's your albuterol or Zopanex or Proventil or what have you, and some others, that sends a message to the muscle to relax. And that message only lasts 4 hours. So during an asthma attack triggered by a virus, you may be doing every 4-hour treatments for a few days. Preventatives that basically target the inflammation, which is causing the lining of those airways to swell up, and then also for them to secrete mucus. Those are your inhaled steroids and also your leukotriene receptor antagonists like Singulair or Montelukast. But they are generally slower acting than the albuterol, and so they work in conjunction. However, the lines of, so that used to be probably the way all of you were trained, and certainly the way I was trained, is for symptoms, you take your albuterol or levalbuterol every 4 hours as needed. And then you take, if you have bad asthma, you take your daily medicine. So the biggest change in international guidelines for asthma care is what we're about to go through. So a reliever, we don't call them rescue inhalers anymore. We call them relievers because we don't want somebody waiting until they need rescuing to pull out their quick reliever. We want them to get relief whenever they need it, even if it's just relief from coughing. So the definition of a reliever is an asthma inhaler taken as needed for quick relief of asthma symptoms. These can be given for symptom relief, but also before exercise. But now, instead of just SABA, a SABA is a short-acting beta agonist. That's your albuterol and levalbuterol. So now we have as needed a type of therapy called the MART or SMART. That we use ICS and formoterol. So that's an inhaled corticosteroid and formoterol combined. That's like your Symbicort is the brand name, or Dulera or Brenya. And we do that as needed sometimes. And then there's a new medicine on the market that uses budesonide, another inhaled steroid, and albuterol for AIR therapy, AIR, anti-inflammatory reliever therapy. The brand name of this medicine is called Air Supra, and that's also as needed. We're going to talk a little bit more about that. So the picture just got complicated of the medicines and strategies we use. So let's go to the green box here first. So this is AIR therapy, anti-inflammatory reliever therapy. So this is basically using an inhaler with a steroid and then something like albuterol that works fast to open those airways. Using this on an as-needed basis instead of just using only albuterol as needed. So this is for your intermittent asthmatics. So they don't have symptoms every day. They basically only need something when they have a treatment. In the old days, like when I was trained, we would just give albuterol PRN to these patients. But what research has showed over time is that if you do that, they still go to the ER. They still die. They still have these bad outcomes because you're just giving albuterol. But if you add an inhaled steroid to this, to every time they take albuterol, they're on a steroid. You target both reasons for them to have, tight airways. The smooth muscle, you relax that, and then the inflammation of the walls of their airways, you also target that. And so this is not caught on. Even some of my partners are, we're all in the process of starting to adopt these recommendations. And like I said, the medication that we can use for AIR therapy just came on the market and is finally now being stocked at some pharmacies. Okay, MART or SMART therapy. I like SMART therapy. That's more the state side or the American name. MART is what's used in Europe. Same concept, same identical medications, just slightly different acronym. So this stands for single maintenance and reliever therapy. So this is where you are taking an inhaler twice a day, every day, and then you use that same inhaler rather than a different one for your as needed symptom relief. So only inhaled steroids with the long-acting beta agonist called formoterol can be used for this. And we're going to show you the examples in the next slide of what those look like. So red box is the reliever therapy. So you've got nebulizers, you've got inhalers, you've got dry powder inhalers here at the bottom with the ProAir RespiClick and the ProAir DigiHaler. You've got a slow mist inhaler device called Combivent, which has albuterol and ipratropium. And then, of course, you have old school Atrovent inhaler that is occasionally used, particularly for heart patients, because it does not excite the heart in the way that albuterol seems to. Just a quick piece of information on the difference between Xopenex or levalbuterol and albuterol. So for practical purposes, there's no difference. Albuterol is a mixture of the albuterol molecule that has left hand and right hand versions of the same molecule. Xopenex, called levalbuterol, is literally just the left hand version of this molecule. So they essentially do the same thing. Xopenex or levalbuterol seems to have a slightly less sort of stimulating and effect on the patient and the heart compared to albuterol, but they both work equally well to open those airways. The milligrams are different because albuterol is a mixture. So if you think of it, 1 milligram of albuterol equals half a milligram of levalbuterol. Still, it's like you give 1 vial of each, or you do 2 puffs of each inhaler, but that's the only difference. So we'll go down to the green box in the lower right hand corner of your screen. So this is Air Supra. It just came available. It was FDA approved a year ago, and then pharmacies just started stocking it last month. This is budesonide, or same thing that's in Pulmicort. Budesonide and albuterol in 1 inhaler. This is just for use as needed for the intermittent asthmatics with symptoms. So moving to the pinkish, maroonish kind of box, so that's Smart Therapy. So there you've got three options. Symbicort and Dolera are the name brands. Brenya is what's called a branded generic of Symbicort. The amounts and the components of Brenya are identical to Symbicort. So you may see any of those three used PRN, and that's A-OK. It's just different. Okay, so the way I, as a physician, usually communicate with the school nurses for my patients is with something like this, an asthma action plan. This is one example of which there are many. As you know, they're set up like a traffic light. Green is good, that's your daily medicine. Yellow is some symptoms, red is lots of symptoms. And the thing I like about the Cook Asthma Action Plan is that it talks about coughing and wheezing in the same sentences. So green zone is going to be their daily controllers that they never change. But green zone may include taking a medicine before exercise. This could be either their air albuterol or their air supra for air therapy, or their Symbicort for the smart therapy. Any of those three inhalers can be used before exercise. Yellow zone, they're having some symptoms, and you're starting to do treatments generally every 4 hours or so. And then red zone is the yellow zone treatments aren't working, so step this up, do more, and also get the patient to the emergency room. How we give, the next part of our talk, we're going to discuss how to give these devices. This is a spacer many of you guys have seen before. It's disposable. It's called the light air chamber. It's very nice. It's actually a complex piece of cardboard and plastic. So their manufacturer's website cut one open for us. And so you can see it's got a one-way exhalation valve and a one-way inhalation valve. That's important. So if the patient is young and is blowing through the mouthpiece instead of inhaling, they don't blow the medicine out because of these one-way valves. So that's a really important feature. We're gonna watch a quick video on how to use that. Yep, there we go.
Squeeze the device to make the light air pop up fully. The side panels will snap into place. Remove the cap from the inhaler. Check that there are no objects in the light air spacer or inhaler. Shake the inhaler for 5 seconds. Insert the mouthpiece of the inhaler into the light air inhaler port. Ask the student to firmly grab the light air with their thumb and fingers on either side at the point where they can feel the cardboard inner wall. They should gently squeeze the side panels to ensure the most effective treatment. The student should close their lips firmly around the small holes on the mouthpiece of the light air. Ask the student to exhale fully into the mouthpiece. As the student starts to breathe in slowly and deeply, they should press the canister 1 time to release the medication. Remind them to keep breathing in slowly and deeply. Ask them to hold their breath for 10 seconds, then breathe out slowly. Wait 60 seconds and repeat to provide a second puff of medication. Have the student rinse with water and spit out. Return flattened light air to unsealed plastic container to air dry and store in designated location. No cleaning, disinfection, or sterilization is needed. Remove gloves and wash hands using proper technique. Put on clean gloves and wipe the MDI canister and mouthpiece with an alcohol pad. Replace the cap and return to designated location. Remove PPE and wash hands.
Okay, there we go. You may see other spacers. There's a lot on the market. This is just an example of some of them. They all do good work, and they're all generally designed the same, much like the cardboard one. So there's a cap and a mouthpiece. followed by a one-way inspiratory valve, and then a low resistance one-way expiratory valve, and then a big holding chamber for the medication that's got an anti-static lining to prevent medication from sticking. So that you've got basically three options when somebody pulls out a spacer or an inhaler. You can give the spacer with just the inhaler and no mouthpiece, where they put their mouth directly on the spacer. Younger children will have a spacer with a mask, and then sometimes kids will just use the inhaler without the spacer, which is, in my opinion, less than ideal, but sometimes effective. These are, I put all the the basic instructions, I lined them up together so you could see they're generally the same thing. Remember the rule of 10. So you're either doing a 10-second breath hold for the inhaler and the spacer, or the inhaler without the spacer, or you're doing 10 regular in and out breaths if the patient has the mask. Another difference is when you're using an inhaler with the spacer, it's a slow, full, deep breath in, and then you hold your breath. When you're using just the inhaler with no spacer, you got to take a fast, full, deep breath in. A spacer has a little whistle or harmonica note on it that if you breathe in too fast, you hear this whistle or harmonica sound, and that lets you know, hey, slow down. You don't want to hear that sound when you're breathing. The red box at the top of your screen is just a reminder. If it's a brand new inhaler, or you hardly ever need it, every few weeks is how often the kid needs it, you want to prime a new inhaler, or a sort of something that's been sitting for a while, and that's generally 4 puffs into the air, and then it's essentially loaded. So some of your patients will have nebulizers. Going to briefly go through the anatomy. So you've got your big box, or the machine, that's actually an air compressor. Then you've got coming out of that is the clear plastic nebulizer tubing, which connects to a little plastic cylinder called the nebulizer cup, which either has a mouthpiece sticking out of it like this one does, or a mask for your younger patients. We're going to quickly go through a video on how to use that, just to make sure. It's very simple, but not necessarily intuitive when you pull it out of the box for the first time.
When you're ready to add the medication, unscrew the top of the side stream nebulizer cup and pour in the prescribed medication. The side stream nebulizer cup is suitable for 2 milliliter to 10 milliliter doses. Screw the top back onto the nebulizer cup and attach either the nebulizer mouthpiece or the face mask. Don't lay the side stream down on its side because the medication will spill out. You can use the parking post on your device for securing the side stream when not in use. To take the treatment, sit in an upright position, relax and switch on the unit. Make sure mist is visibly coming from the mouthpiece or mask. If using a mask, place securely in position over your nose and mouth and breathe slowly in and out through your mouth. Or, if using the mouthpiece, take it between your teeth, surround it with your lips and breathe in and out slowly through your mouth. When the side stream begins to work intermittently and sputters, the treatment is finished. There is no need to nebulize every drop of your medication. There will always be a small amount left in the medicine cup. When your treatment is complete, turn the power switch off and unplug the device from the...
Okay. So a couple of other devices you may encounter. So the dry powder inhaler called the ProAir RespiClick and the ProAir DigiHaler. So these are the devices that have little tiny tablets of medication in them. And when you open them, like this one, when you open it, you'll hear a click, and that pulverizes this tablet. And then the patient does a really big, fast inhale to essentially provide the power to aerosolize that power. So they do a full, deep, fast inhale with that. then they hold their breath for 10 seconds, and then they close the device. You essentially use this 2 to 4 puffs, just like you would the albuterol, depending on the asthma action plan. Something you will very infrequently come across is the Combivent Respimat. Combivent is albuterol plus ipratropium, so it's 2 medicines in one. Technically, it's only approved for use, I think, in COPD in the adult world, but I mean, we've been using these medicines for acute asthma for 30, 40 years or longer. So it's kind of silly that it's not FDA approved because it's used kind of all the time. This is generally the more severe asthmatics. So this is how you use it. So you turn it, open it, and then do a long, slow breath in after you press this button. This is called a slow mist inhaler. If you want to see some videos of it, go to combivent.com on how to use it. There's also, when you first pull it out of the box, you've got to do a couple of steps to essentially load it the first time. Load this little cartridge that you see in the image on the bottom of your slide. And that's kind of hard to explain. So I would watch the video if you do come across this before messing with it. It's easy to use, but it's hard to load, if that makes sense. I have asthma, and I've had to use Combivent before, and it is complicated to load. Cook Children's also has created their own videos for the various ways to use an inhaler, as well as the home nebulizer. If you're interested in them, they've just been shared onto YouTube, and so you can look at those at your leisure. Here's some references, and that's what I got for y'all today. Anybody have any questions?
Thank you, Dr. Robertson. We'll invite, I don't see any questions in the chat or Q&A section at this point, so we can move forward with Abigail's part of the presentation, but I would invite anybody as you think on this information and absorb what's being shared today, please feel free to enter your questions in the chat box, and we will have time after Abigail shares with us to revisit and address whatever you have to share.
So my name is Abigail, and I'm a child life specialist here at Cook Children's, and I serve in our pulmonary clinic. And so I was originally reached out to help you guys with just some technical or coping issues that might be happening in the nursing office whenever the kiddos are coming in to do their reliever inhalers. And so some of this might seem kind of simple, but a lot of it really is just some simple tips to help with some compliance and just some of those issues that you guys expressed are happening. So I'll give a little brief slide just about Child Life and what we do and kind of our motive behind helping kiddos. And then I'm going to talk about building rapport, some distraction options during this time when the kiddos are in the nurse office, some education, and then a few ideas for some individualized systems. And while I work in a different setting than you guys, I was a second grade teacher for a few years. So I have a little bit of insight into just kind of how the day flows, or, kids getting to the nurse and things like that. But I know we have the Q&A, but I'm also happy for you guys to email me specific questions if there are certain scenarios that you see happening a lot, and we can kind of brainstorm how we can help support that specific kiddo. Okay, so the next slide. Okay, so what does a certified child life specialist do? So child life specialists are professionals trained in child development and specialize in working with children in healthcare settings. The role of a child life specialist is to help patients understand and cope with the challenges of hospital experiences and their diagnosis. They aim to reduce stress and anxiety in the medical setting and help create emotional safety for children and families. Child life specialists help children cope through therapeutic play, diagnosis education, age-appropriate preparation, and expressive activities. They also provide information, support, and guidance to patients, siblings, the question box is covering, and other family members. Child life specialists can help your child understand their diagnosis and hospital experiences by using age-appropriate language, videos, teaching dolls, medical play, books, and more. The specialist may also teach relaxation and distraction techniques to help reduce stress or anxiety about needles and other medical fears. So this one's pretty specific to a hospital setting, but I'm going to teach you guys some of these skills that I get to use every day that you can easily use in the nurse office. So you can leave it on this slide, Courtney, or you can just put it on me while I talk. I just have a few notes with me. So the first thing that I want to talk about is building rapport. And as teachers and nurses of elementary, middle, and high school students, I know that you guys are trained in this, or at least know what building rapport is. But basically, it's just creating those meaningful connections, whether they're small and quick or over a long period of time with the students, that will overall help with just their coping with doing their asthma treatment, as well as their compliance with doing their asthma treatment while they are in the school setting. I know Marquietta and Courtney had let me know that some of the barriers that we face too with kiddos in school is that we don't know if they're doing their treatment at home. And while that is out of our control, both in the hospital setting and at the school setting, I really do think that building these relationships with kids will make them more eager to do their treatment while they are in the school setting. And so I just have a few ideas for school age, which school ages I'm referring from kinder through middle school, and then kind of teens, I'm doing middle school through high school. So for school age, I said some easy things that you can talk to the kiddos about just to build that relationship with them. Talking about what shows they're watching, what YouTube videos they like to watch, video games, sports, their friends, what they like to wear, or I know some schools, they have dress codes, and so what accessories do they use? So little things like that can really show that you're buying into the kid and that you're not just there to give them the inhaler and then see them out the door. It really does make a difference when you show the child that you are invested in their just presence and existence. And I do understand that these kiddos are coming in this kind of sometimes in a panic state where you need to administer the inhaler quickly. So this is something that can be done afterwards, just for a few minutes before you send them back to class or to recess or to PE, that over time will have a meaningful impact. For teens, I just mentioned talking to them similarly about sports, music, any upcoming fun events that they have going on. And then just getting to know them, whatever they're comfortable sharing. With teens especially, it might feel, teens are very private, and we want to respect their privacy and respect their independence that they're gaining. And so it can be hard to kind of teeter on the line of being kind of an adult or a parent that's making them do something, but also being there as just a supportive person or kind of a friend that's trying to get to know them. So just making sure with the teens that you're coming at it not from a like a parent perspective of you have to do this, but just trying to get to know them, even if it's just a little bit, that you can, so that they see you as an ally or on their side. And then, so that is for building rapport. And then we'll talk a little bit about distraction, which this could definitely be your best friend when we're talking about little ones. One of the things that I heard was that for some of the little kids, having trouble with them staying still or just getting them to focus so that they can do their inhaler for 10 seconds, which probably feels like 10 minutes to them. I even practice with our respiratory therapist here. And for me, 10 seconds felt like a long time to get me to, relax, to concentrate on taking that big, deep breath, holding for 10 seconds and then letting it out. So I can't imagine a second grader that's missing recess, or, missing the lunch line or PE when they're picking teams or whatever is going on. So a little bit about distraction. One thing that I use every single day in my practice is an I Spy sheet. It is actually on my badge, and it's just a little picture. I have a couple that I can switch through. And so it's super easy. I even have like just a plain one with stars that I can use with kiddos to help engage them quickly. And so how this can help you guys is if you have a kiddo coming into the nurse office, they have a hard time focusing and getting their attention quickly because they're having difficulty breathing or they're coughing. We need this to move quickly. So getting them set up and having an item like something to distract them with, like an I Spy tool that they can look at while they're doing that 10-second breath hold. So part of my presentation today is I've spoken with my team here at the hospital, and we are going to be able to provide you guys with like a laminated version of an I Spy picture if you guys would like that. And so we'll talk about how we'll be sending out an email so that you can let me know if you want it and I can create one for you guys. But basically how you can use it is during that 10-second breath hold, or even after, just for a minute or two. Again, building that rapport, just playing a quick little game. It doesn't have to be I Spy something blue. It can be if they're holding their breath and you don't want them to talk, can you point to something blue? Can you point to 3 things that have a hat on? Mine are all little Disney characters. So anything you can think of, even if for the stars, can you circle with your finger the biggest star? So really getting them to focus on one thing at a time. Helping them to not panic, to focus on one thing, do the 10-second breath, take a little break, maybe play a quick round of the I Spy, and then do the inhaler again as needed and as prescribed. So that's my favorite little distraction. Another thing that can be helpful during this time for the little ones who like to wiggle, or just ones that you can't seem to get them to do their inhaler, is anything that they can put in their hands to fidget with. Even something as simple as like the little pom-poms that you decorate, Christmas cards with, or you make arts and crafts with, a pipe cleaner that they can pull on and rub their fingers on. Anything you can put in their hands that is not a device that they can feel texture on. So this doesn't have to be the most expensive squishy toy or a squishmallow or some fancy fidget that's $20 from Amazon. It can be any kind of texture that they can feel. This can also be helpful for any kiddos who are struggling to calm down just to initiate taking the inhaler. And so we see that sometimes here in our inpatient settings, and also sometimes in the clinic when we're teaching kids how to use their inhalers. I have a lot of kids who have a lot of fear about either the mask or the nebulizer or the spacer. And so giving them something for their hands to focus on and for their mind to focus on different textures or different things in their hands can really help. The dollar store is great for this kind of stuff. Squishies, Play-Doh, bouncy ball, pipe cleaners, those little pom-pom puffies, anything that they can get their hands on should be really helpful to you guys. Another one that I like to use is music. I use music all the time in my practice, letting the kiddo pick something out that they want to listen to. I know that this is a really short interaction, but it can really be helpful, especially if this is a kiddo maybe you're seeing twice a week or every week, and you're in a consistent spot to where you can maybe get to know that this kiddo likes a certain song. Or again, even if you have them stay in your office for a minute after to listen to the song, just building that rapport so that they're comfortable coming back. That can be the same for teens too. And I do it here with the kiddos and the teens. I just say, play something that you would play in front of your mom. It can still be cool and, you know, whatever you want to listen to, but we are at a children's hospital. We are at a school. So keep it, you know, at least PG-13. And then for the little ones, Google Timer. So I use this all the time in my classroom, and I use it here as well with some of my procedures that I do that are timed. Google Timer has a lot of really fun timers that you can put in just for 10 seconds, and it is a visual representation of time because some of our elementary school kiddos do not know how to tell time yet, or they're learning, or they have educational needs that don't allow them to understand that concept of counting down. And so giving them a visual representation. There's one that's like a piece of pizza and the slices go away as the time's passing. That's the one I can think of off the top of my head. That can be really helpful for kids, giving them a visual. So that is kind of my distraction section. As far as education, I think this is really, really important for all ages, but can you guys have a unique opportunity to really pour into these high schoolers and middle schoolers who are transitioning to high school, where sports is a huge deal. And then if they're older high schoolers where they might be moving onto a more independent life stage, maybe they're moving out of the house when they graduate, or they're going off to school, something like that. I think you guys have a great opportunity to really pour into these age groups. So one thing in regards to education about asthma is we don't know what these kids are getting at home or what they got when they were diagnosed. Were they even listening? Were they in the room when their primary care physician or their pulmonologist was talking to them about treatment? You would hope that they were listening, but sometimes that just doesn't happen and we can't control that. Sometimes they're playing in the room with someone like me so that mom can make sure she's hearing the instructions. So a little bit of education. One thing I would encourage you is to use honest language. So not saying we need to do this so you can feel better. That is pretty vague. So even using something like, we need to use this inhaler so that you can breathe better, or so that your chest doesn't feel like someone's standing on it or sitting on it. Or do you hear that noise that I know it's not your throat making the noise, but to them, do you hear that noise that your throat's making when you breathe? If we keep doing our inhaler, we can help that noise be a little bit more quiet. So if they're wheezing or coughing. For the older ones, I totally think it is appropriate to talk about with them, whether after they've come and done their reliever inhaler, or they're doing it just before they go to PE and you've got an extra minute, talking to them about, do you know why you have to use this inhaler? You would be surprised at how many teens that I see here in clinic, whether for asthma or cystic fibrosis, that cannot tell me why they are taking a certain medication. And it's not their fault. It's nobody's fault. It's just, I see it as a great opportunity to educate them. Of course, we know the dire consequence of not doing your treatment. And I'm not telling you guys to, use fear to scare them into doing their treatment at all. That will not be successful and it will cause more damage. But just being honest with them, if it's a kiddo that really loves to play football, or they're the basketball star and they think it is so lame that they have to come to the nurse's office to do their inhaler, just putting the responsibility on them, but also kind of forming a partnership of, okay, we're building this rapport with these kids. You love to play basketball. I know you've got a game. I know you're headed to practice in a few minutes. Do you know why it's important that you're taking this medication? And then following it up with, okay, so you know why it's important. We need to do this so that you can go to your game, go to your practice, go to PE. I'm helping you. I want to partner with you so that you can be successful on the basketball court, so that you can be successful at football. I don't want to see you get hurt or get injured or have difficulty breathing and have to have further treatment or get worse than we already are right now. So kind of letting them know that you're partnering with them and it's not you shaking your finger at them or shaming or anything like that, which I know you guys aren't doing, but just teens can interpret things in crazy ways. So we really want to let them know that we're on their side. And then just a few more little tips. Like I said, I know this is a really short interaction that you have with these kids. And Courtney was telling me before, like a couple weeks ago, that some of you rotate through schools or it's just not always the same nurse or students. And so these are things that you can do even if it's not consistent students that you're seeing. Just finding one thing to relate to them on. So whether it's how they have their hair done that day or telling them a joke, having a list of jokes at your desk, anything that you can rattle off to get them to connect on a human level before you go into the medical treatment of it. Just making sure I got all my little tips and tricks. I think that is all. But for sure, if you are interested in having a little I Spy thing made for you, we can create them here and mail them to you. And so we'll be sending out an email so that you guys can get that for your offices.
Thank you so much, Abigail. That's wonderful. I love, as you were sharing that, I was thinking, I want to go back and share your notes or the highlights of your notes as a resource as well when we post the recording, because those are great takeaways that anybody could do. And I really appreciate you offering the resource, the laminated copy of the I Spy for folks who are interested. So thank you for that. I will note there's not too many questions, just two in the chat. The first one is a question about if the slides will be shared with everybody. And so, yes, we'll get the most updated copies of the presentations, and with our presenters' permission, we'll be able to share those online when we post everything. So it may take a little bit of time to get it posted online, but we will share what we have. And so you'll be able to go back and find it and refer back to it, including these resources that Abigail has shared with us today. Let's see, I see a question here. It looks like just one question for Dr. Robertson. So going back to thinking about the medication specifically, and this attendee says, in my earlier training, it was always said that we should not overuse steroids because people can build up a tolerance. Then when they go to the ER, they don't respond to steroids. Can you comment on that?
All right. Yeah, that's a great question. No, you can't build up a tolerance to the inhaled steroids. You can build up a tolerance to the albuterol category of medications if it's given, frequently for long periods of time, and tolerance means you need more and more of the dose of the medicine to achieve the same effect. However, I don't really see this happening in my patients who need albuterol before exercise, because that's rarely every day, and the rarely more than one time a day, depending on the level of athlete. Using the PRN inhaled steroids with the new guidelines, totally fine. No long-term side effects on height or adrenal suppression or immune suppression or any issues with that. Totally safe. The height side, there is a height side effect sort of warning on all inhaled steroids, but it really only applies to number one. The height side effect is tiny. It's like 1.1 centimeters, which is less than half of 1 inch, off of an adult's height, in someone who took inhaled steroids daily for multiple years. So certainly for what they're going to get at the school nurse's office, there would be zero long-term side effect. If you use an inhaled steroid, if the patient is on that to be used in your office, at school, you do want to rinse your mouth out. If they're just getting plain old albuterol or levalbuterol or Combivent or the Atrovent, they don't need to rinse their mouth out. It's just, you just want to clear the mouth out of the steroid. I think that answers that question. You can't build up a resistance to steroids with the way we're talking about using them.
Thank you. And there's a follow-up to that, but I believe you answered it, but I'll just make sure there's nothing else you want to share about it. But someone did also say or ask, are you recommending the SMART therapy be used for those who have exercise-induced asthma also?
Yeah, it can be. And so they would just literally have the one inhaler. They'd use it at the morning or morning and night, for example, and then take the same inhaler again during before exercise. There's a challenge that is probably the reason why SMART therapy is not more commonly used, and that is simply most insurance companies will pay for one inhaler per month of these particular medications. And so if you want to, if you need 3 or 4 inhalers, that can be cost prohibitive. And so, they'll need one of these at school generally, unless they're able to carry it on them. And so that's kind of, there's more of a practical barrier to just kids having to have that at school and at home. As a reason you're not seeing the SMART therapy so much. Also Air Supra. So I consider it safe to use in kids. There's a lot of studies that have been researching the idea of this in children. It's part of the guidelines and the recommendations for your age group of kids. However, Air Supra is currently approved by the FDA only for 18 and up. Don't forget the medicine is albuterol and budesonide. Budesonide is Pulmicort, and budesonide in the nebulizer is approved for use down to 6 months of age. So it's not that the medicine's not safe. It's not that we don't know a lot about the medicine in young children. It's simply that the company that made the inhaler didn't, at this point, has not yet done the, several millions of dollars per studies to get it approved for use in that market. But if you see it, it's totally fine. Don't be worried about that.
Great. There's another question for you, Dr. Robertson. Here we go. How do patients get authorized for the extra doses of ICS when on SMART?
Yeah, good question. So that's on the physician. We generally need to write letters of medical necessity explaining everything to insurance companies so they can have more than one of these inhalers per month. It's a lot easier if they don't happen to go through an entire inhaler a month, because then you can have sort of a stockpile. But yeah, that's a logistical barrier. You're absolutely right. Good question. Anybody else have any other questions?
I'm not seeing any in the chat box, but I will say, Abigail, lots of kudos and thanks to you for the tips you shared and some interest in the laminated tool. So again, we'll follow up by email afterwards, after the event today, for you to express your interest in that laminated tool and connect you with Abigail that way. So thank you both so much. And for you all engaging in the chat. Well, now, and I know Dr. Robertson and Abigail are taking time away from patients to be here today, so I believe they may need to step away, and that is completely understandable. So we'll now pass it over to Dr. Leslie Alsup. She's our program manager for Asthma 411 to share a few brief updates on the program. And I'm going to forward the slide here. There we go.
Wonderful. Thank you so much, everyone. Before I go on, I do want to just send my many thanks to the entire Cook Children's team for this wonderful program and for all they do within the community and to advance the health of children, especially with Asthma 411. Of course, I want to thank Dr. Roberts for the wonderful information and for Abigail's great contributions. And last and certainly not least, to all of our participants. As I can't say often enough, we're so grateful for all that you do every day to care for children in our community. And one of my absolute public health heroes for our children's well-being. So next slide, please. Just getting started. So we'll be talking a little bit about the updates with Asthma 411, and a number of these are going to talk about the unassigned albuterol perspective, which I think is clearly gets a lot of attention, and rightfully so, but I think it is always critical to state again how imperative it is to remember that what we're supporting is not only the unassigned albuterol, but the full range of best practices to improve outcomes for children. And when we discuss this, I tend to break them into these three categories for schools: the preparation for the asthma emergency, which includes quick relief medication, but we know the goal we strive for is that every child would actually have their own quick relief medication from their healthcare provider in a medical home and an asthma action plan. It just doesn't happen often enough. The unassigned albuterol is that backup. A number of things fall into that: education, outreach, and professional development, and then linking to resources, making sure that these children have the health care and the medical care that they need. We have more resources on asthma411.org. And we'll be, talking a little bit more about each of these elements as we go forward. Dr. Roberts' wonderful presentation today does highlight why that albuterol, that quick relief medication, can never solve alone a child's problems with asthma. It's only going to be effective for approximately 4 hours, and that over-reliance on that medication is a risk factor for all adverse outcomes, including fatalities. So next slide, please. I do want to comment just briefly, although many may be aware of this, on the changes that were made in the legislation during the last session that will eventually get implemented through the Texas Administrative Code for our use of unassigned albuterol in Texas. And there were some restrictions there before which have been removed, and that aligns our Texas policy with the national best practice recommendations. So going forward, trained, authorized personnel and volunteers can be designated to provide this if they've received the training. We advocate for nurses, of course, on every campus and in the ratios that are recommended in Healthy People 2030. We know it doesn't always happen, and it's wonderful to know that schools can train and designate other personnel when that's needed. Who may receive? A person reasonably thought to be experiencing respiratory distress, which can be very helpful. We know if a parent hasn't yet, for example, communicated their diagnosis, or possibly it's the first episode that a child's had. Where can that administration be provided? In addition to on the school campuses now, there is an option for school districts to include school events. It's not a requirement. It's a question for school districts to consider what best meets their needs. And the trained personnel, if a policy is adopted, need to be available during regular school hours. The important point there is that's 30 minutes before and after the bell, rather than during all school hours the school is open. That has been a real barrier, I know, with the epinephrine for many school districts. Next slide, please. The important point to know is that the Texas Administrative Code are the rules that are needed in order to implement this new legislation. And those are very much under development right now. It's the Stock Epinephrine Auto-Injector Committee that's responsible for doing that. And they have just gotten started appointing a subcommittee to develop those new rules. What you'll be seeing over the next couple of months is they will be coming out with proposed rules, and there will be an opportunity at that point for public comment. We can help make sure that that word gets out for anyone who's interested in putting their comments and their perspectives as those are developed. Often it's only a few weeks or a couple of weeks that the comment period is open. So I'll be making sure to communicate that to school health administrators and make sure it gets posted in newsletters. Those comments can only be directed about the rules. We cannot change anything that's already in the legislation. What I do want to emphasize that the perspectives of our school nurses who are there every day caring for children are critical. It's always my goal to advocate for this based on what I have heard from you in conversations or seen in comments that you include in our surveys, but please do keep an eye open for this. And if you've got suggestions or see things that could be changed to work better, please do put those comments in and make them available. The final rules, the goal is that they will be ready to implement in March of 2025. So that is a long way out. And while I like people to know it's coming, it isn't there yet. And the key thing always during this transition between when legislation is passed and when the administrative code is to be aware of your school district's policy. Make sure you know that and are aligning with that. The last thing I'll mention regarding all of this, I know that the reporting and the documentation systems, which are so key, also can be very, very, very difficult. And we will continue to look for ways, perhaps through technological approaches, where we can streamline those, the reports that are required, but that has not, no changes were made in that area. Next slide, please. This is something that we were able to share with our health service administrators in the fall, and I want to begin sharing it with our school nurses as well. We had our comprehensive evaluation that included all of the professional development, but we also pulled this together looking at just over 80% of all students who received unassigned albuterol have been able to return to class. We estimate, and I think it's quite conservative, about 4,800 reclaimed instructional hours for children who weren't well enough to be able to stay in their classroom, who came down to their school health office, received this intervention, and were able to safely complete their school day and be ready to learn. We've made an estimate at the financial benefits for schools, family, and the community at about $500,000. That includes prevented EMS calls, lost family wages, attendance, and the like. We have our survey, and we are so grateful for all of the nurses and health staff that complete this every year. Nearly everyone reported they were either somewhat or very satisfied with the program. Now, with all of that, we had lots of comments about what challenges are there and what changes need to be made or how it can be improved. That is extremely valuable as well. But overall, people reported a high level of satisfaction, and a majority currently of the unassigned albuterol that's being reported to the state systems are coming from the region here in the Tarrant County area, where our our Tarrant area consortium is based. A couple of points I want to make. First of all, of course, is an enormous shout out to the nurses and health staff that are implementing these programs. I think it's a huge contribution to the well-being of kids in our community. Secondly, I want to thank everyone who does this reporting. As difficult as it is, it's not only helping those kiddos, but it helps us to support our programs and to communicate to others about why this is worthwhile and potentially beneficial. And third, the majority right now of school districts that have passed these policies supporting unassigned albuterol are here in this partnership. So hopefully by sharing this kind of information, we can encourage some of those who are considering it but haven't done it yet. We did include this in all of the advocating for national guidelines that was done. And again, we can't have this information to report unless not only we have the program, but your critical reporting and documentation that you do. Thank you. Next slide. So as I consider some of the updates, I want to take a moment to give a shout out to Northwest Independent School District and say just a couple of words about the wonderful work they're doing. As we mentioned with our model, we're always supporting comprehensive school asthma services, and we know that's extremely difficult to do with our existing models for health service delivery. And we started with a mini challenge to get extra support for nursing hours, and I want to give a shout out to Rebecca DeLaccio-Basley up in Northwest ISD for her leadership in getting started and moving forward, and Rachel Rivera, who has been developing these tools and strategies to implement it. They've done a wonderful job and indicated our contact information could be included. They're doing asthma self-management education, post-inhaler follow-ups. And we know that not all children who use unassigned albuterol, but some, especially those who may come back more than once or twice, may be at risk for not having the health and medical care they need, not having that asthma education. So Rachel has been developing these wonderful tools and strategies for doing those post-inhaler follow-up, using the asthma control test to identify children who may not have adequately controlled asthma and contacting their families. They can also be used, the asthma control test, which can be done very quickly. It can be done for longitudinal tracking to see whether a child is maybe improving or if their asthma management might be deteriorating. 515 students that she included in her asthma self-management education program, which is fantastic. So big shout out to them. It's our hope that we can disseminate and make these tools more widely available, but wonderful work. And our last slide. So just to wrap up, I want to mention we have a wonderful new team member, Juana Escobedo Bermudez, who is working with us. She is a community health worker and is bilingual. So we're thrilled she's part of our team now. We want to continue to expand the support for follow-up after the standing delegation order use. Please do keep looking for more information about that. And May is going to be Asthma and Allergy Awareness Month right around the corner. It will be time to wrap up our school year, so please keep an eye out for updates on that with our newsletter and website. And next slide. And I'll just say thank you all so very much again. Really appreciate the opportunity to connect.
Thank you, Larry, for providing the update for all of us. And special thank you to Dr. Robertson and Abigail for your wonderful presentation. And to many, thanks to all of you for engaging with us today. I'm Marquita Jones, the Program Coordinator for the Community Asthma Initiative here at the Good Children's Center for Community Health. And I would like to invite you to visit our webpage at goodchildrencommunity.org to find asthma resources and downloadable deliverables. I'd also like to thank all the Asthma 411 partners and all the participating school districts. And many thanks to you and your staff for making it easy to serve you all. As a reminder, please check your email in the coming days for the event evaluation, which you will receive your free CE. The email will come from Jean Hoffler, so just be aware and make sure you check your spam. Make sure you also enter your name and credentials in the and email in our chat box in order to receive your free CE. Today's recording and link to the CEs will be posted online at goodchildrencommunity.org in the coming weeks. We'll notify you when it's available, so please share with your colleagues who couldn't be here today. For those who are unable to attend and would like to receive the CE, they can watch the recording and complete the evaluation by the end of 2024. The details for that will be listed in a follow-up email. So watch out for that and share with others. With that, I want to say thank you again for joining us, and we hope you have a great afternoon.